Hi, my name is Candace Nelson. I'm a student at the University of New England studying applied nutrition, and I'm here today to present my research proposal for B12 anemia and its effect on depression. The symptoms of B12 deficiency or anemia start out pretty subtle. They could be symptoms of a lot of different conditions. They include fatigue, weakness, lack of energy, decreased appetite. But left untreated, it can lead to more serious conditions like dementia, depression, and neurological disorders. So it's important to identify. B12 is needed for a healthy supply of red blood cells in the body. Without those, oxygen doesn't move around the body effectively, and that's what makes us tired or lack energy. Deficiency is associated with a vegan diet, celiac or Crohn's disease, increased age. There are also absorption issues that can lead to deficiency or anemia. B12 is commonly found in animal sources of food like dairy, eggs, meat, and shellfish, which is why vegans and vegetarians are often deficient. It's also fortified in some bread and cereal products. Adults should consume 2.4 micrograms per day, and anemia or deficiency can be treated with B12 injections or supplements that are generally easier for the body to absorb. Supplements are considered to be safe, and no upper limit has been established. B12 deficiency was once just accepted as a normal part of aging, but current research shows that it can be treated and should be treated to avoid a negative effect on public health. Deficiency isn't super common. Only 1 to 2% of the elderly population has a clinical deficiency. It's estimated that another 10 to 20% has subclinical deficiency. It's also important to note that a B12 deficiency can be difficult to recognize, again, because the symptoms are quite subtle in the beginning, but also because high amounts of folic acid in the blood can mask a B12 deficiency. But it's important to diagnose because B vitamins have been linked to depression, which is also very common in the older population. Research suggests that depression might be involved in the emergence of low levels of B vitamins, which is interesting. Common knowledge would just suggest that it's lack of nutrition that leads to depression, but research shows that it could be the opposite. Lower serum levels of folate have been related to higher severity of depression, and that's before treatment. And patients with the highest plasma folate levels have shown the lowest degree of mood disorder and duration of depressive episodes. So this is important because it makes it clear that B vitamins do impact our mental health. A study examined vitamin B intake through diet and had participants take an assessment of depressive symptoms. The results showed that the higher the intake of vitamins B6 and B12, the lower the incidence of depressive symptoms. That was over an average of 7.2 years. In the short term, however, B vitamins have not shown to ward off depressive symptoms. They do appear to reduce severity of depressive symptoms with prolonged use. So in the same study, folate was not seen as a protector against depression. However, participants had a high folate intake in their diet. And B6 and B12 have shown to increase response to antidepressant treatment over the course of a year. So nutrition and depression seem to be highly connected. Nutrition activates hormonal neurotransmitters, signaling pathways to the gut, which modulate brain functions like appetite, sleep, energy, the reward center, cognitive function, and mood. Those things also trigger eating behavior. Studies have shown that adherence to a healthy diet and likelihood of depression have been linked. And it's likely that diet and mental health impact one another. It could go either way, that diet impacts mental health or mental health impacts diet. And that's been shown mostly in studies of dietary patterns as opposed to just focusing on one nutrient. So the study hypothesis and research question. First is the research question. Does treating major depression improve vitamin B12 serum levels? The hypothesis is that if subjects with a diagnosis of depression reduce their depressive symptoms, they will in turn improve their vitamin B12 serum levels. To test this, we will recruit 185 participants over the age of 55 with a diagnosis of depression. We will exclude any volunteers who have serious mood disorders other than depression, such as psychosis or a history of bulimia. We'll have also anybody who takes a vitamin B supplement already or has a medical condition that affects their absorption of vitamin B12. We'll ask them to take a baseline depressive symptoms assessment and a frequent foods questionnaire and a vitamin B12 serum test. We'll repeat those every 6 weeks to see how they're improving and if they change together. The risks should be minimal. It's possible that our participants will have an emotional reaction to the assessments asking about their food intake or depressive symptoms. The risk of blood draw is pretty minimal, usually according to the Centers for Disease Control. It could include discomfort, lightheadedness, redness, bruising, or swelling at the site. In very rare circumstances, an infection could occur. In response to their participation, participants will receive a free 1-hour mental health counseling session per month with their healthcare provider. We want to encourage them to continue getting treatment for their mental health condition. The study will also adhere to the Belmont Principle. The study will be designed with respect and appreciation for our human subjects. They'll be recruited through mental health professionals, and the mental health professionals can give them information about the study. They'll have contact information and ample time to decide if participation is right for them. We'll ask them to sign a consent form and meet with a research assistant to do the initial assessment and the blood draw and answer any questions they might have. Participants can choose to withdraw at any time, and that will not affect their relationship with the research team or their mental health provider. We'll take steps to protect any personal information. It'll be on a protected password, protected tablet computer, and only the research team will have access. We'll also report any data in aggregate form only, not anything attributed to one participant. The individual information and reports will just be kept on the tablet computer with a number not identified by the participant's name. In case that does get in somebody else's hands, they won't be able to link it together. And there'll be no discrimination for who can benefit or participate in this study. We're really looking for anybody over age 55 with depressive symptoms. Researchers will use regression testing to determine predictors of vitamin B12 levels given a score on the depressive symptoms assessment. We use a t-statistic to determine if the results are significant at the 0.05 critical alpha level. And if so, we will accept the hypothesis that depressive symptoms affects B12 serum levels. The study is not without its limitations. It's been very difficult to find a causal relationship between mental health and diet, in part because capturing both dietary intake and measuring mental health have a high level of error. So it's difficult to eliminate causes of serum B12 levels. Several things can affect those levels. Still, I believe this study has a lot of value. As the population in the United States continues to age, incidence of both depression and B12 deficiency are expected to increase. So it's crucial to treat both conditions and to better understand the relationship between mental health and our diet. This study could help influence mental health public policy. But thank you very much for your time in hearing my proposal. Thank you.